Good afternoon, everybody. Welcome to this webinar. We're going to be starting in just a minute or so, just giving people a chance to continue to sign in. So we watch that number of participants shooting upwards. I think we've learned over the last 18 months or so, there's this little buffer period that's always put in of between 1 and 2 minutes at the start of every Zoom call, just to give people a chance to settle in and settle down. Great. Well, a warm welcome to everybody, wherever you may be around the world. My name's Tim Minshall. I'm head of the Institute for Manufacturing, and there are 3 of us involved in this presentation. And I'm joined by Rob Glue, if you want to just say hi and who you are.
Hi, I'm Rob. I'm a PhD student studying temporary logistics at the IFM as well.
And Darius Dene.
Hi, so my name is Darius. I graduated from MET in 2020, and I'm currently managing the logistics for the COVID-19 testing program.
And many thanks to Darius and Rob for joining us today. So they're going to disappear for a little while I do the front end of this before we hand over to the real useful content that they're going to be providing. So the way we are going to structure this is there's a bit of an overview from me, and then we're going to dig down into a couple of example projects of the ways in which engineers have done absolutely extraordinary things in very difficult circumstances. So the 2 projects will be described by Rob and then Darius. And then I'll try to just draw a couple of themes together at the end. And then we've got a bit of time for Q&A. If people would like to pose any questions to either Rob or Darius, or make general comments on this particular issue about what have we learned from this experience and how do we make sure that learning gets fed into where it's needed. If you have any questions, you can at any time just type them into the Q&A, press the Q&A button at the bottom of your screen and just type them in there. And Lisa and Ella will be there watching out for those. I think those are the only housekeeping rules I need to say, other than this is being recorded. Okay, so this first bit will take about sort of 15-20 minutes to set the scene before I hand over first to Rob for the first detailed project. So it seems very strange to be doing this now, but I think just to take a breath and remember where we were back in March 2020. There was that strange sensation in the UK, speaking from a UK perspective, that something significant and bad was happening, but it felt like it was something that was happening somewhere else. And then very quickly, that horrible dawning realization that it was affecting the whole world, and we were going to be affected in the UK as much as anybody else. Talk of not just it was a thing that could be dealt with swiftly, but this was a huge and complicated problem. You might recall this picture appearing all over the place to try and get this message across, that the thing we need to do is to ensure that our healthcare systems don't collapse in the face of this pandemic. We saw the wave of the pandemic shifting across the world, and particular, I think, trigger moment in the UK was around what was happening in Italy, the awful situation they were facing there. And again, that realization in the UK that this was going to happen to us as well, and very soon. And it wasn't just about those who were falling sick and suffering complications as a result and getting very ill and dying, but also the fact that it was not just the patients, it was then the whole healthcare system was struggling, as of course the knock-on effect of having lots of healthcare workers taken out of the system at a time when the healthcare system was under enormous pressure. Again, a quick UK example, but this was replicated elsewhere. Things were needed to ensure we were prepared to respond to the pandemic, and estimates were given of what was needed and what we actually had. And the example posted here of the ventilators, the models showing what was needed and then looking in the cupboard and finding what was actually there. Very frightening moment. But it wasn't just complicated medical equipment, it was the simplest things were also suddenly in short supply. And the approach we'd taken to dealing with this in the past, the UK had taken, just wasn't working, or certainly wasn't working in the short term. So that was the context that we all know well, and sadly, just to remind us of how bad that situation was. So what I'm going to do is just paint a picture of some of the things that engineers did to respond to this. And this is all then leading up to a reflection on, so what do we learn from this? How have we made things more resilient for the next shock that may strike any particular economy or society or whatever it may be? And many of these examples are drawn from Cambridge, but we're drawing in from the university, but also in the local community here in Cambridge, but also pointing to examples elsewhere across the UK and across the world. So I'm going to group the examples broadly into three. And there are two domains we look at. Firstly, that was what was done locally and regionally, and what was done nationally and internationally. And on the local side, a particular way, a way that engineers could support a huge shock hitting the healthcare system was around hospital logistics. We also saw the role of engineers getting involved in advising government, saying there are now so many uncertainties. What can be usefully passed on to government to say, this may help you make better decisions about all sorts of COVID-related issues. And then there's the bit perhaps where you might expect engineers to be doing more work around physical products, getting the right product made and delivered to the right place at the right time, at the right cost, at the right quality. So there's the logistics bit, the policy bit, and the products bit. If we just pick up on the logistics bit, there was this extraordinary moment where it was realized that the healthcare system was under immense pressure, and there were many unanswered questions that were causing potentially a huge impact on the delivery of basic healthcare services, as well as coping with this massive influx of patients, either what actually happened, but also what was predicted to happen. And so as one example, some of our graduate students who were in the UK, and during that time when students were sent home, these were unable to return home. We also had some academic colleagues who were able to get involved in supporting the local hospital, and we had hospital managers and senior members of the hospital team in a very positive position to say, look, we know we have problems here, can you help us? And we were able to help with a few things. So I'm just going to talk briefly about, as an example, 3 projects that some of our students did with support from some of our academic staff, but also the key bit to emphasize here was the role played by colleagues within the NHS. With all the pressures they were under, still finding time to say, hang on, we can draw on help from outside. And that skill of being able to draw in help at the right time, at the right place, is something, again, we'll come back to at the end. So 3 quick projects. One of them was, if you have lots of patients who've got respiratory problems triggered by, in this case, COVID, you need a reliable oxygen supply. And in the early days of COVID, the first surge and the second surge, there was a real concern that the infrastructure for delivering oxygen wasn't as reliable as, they didn't know how reliable it would be when massively scaled. So again, students deployed to do good engineering approaches, which is to say, what's actually going on here? Don't assume anything. What are the questions we need to ask about the oxygen supply? And then finding out, going through a very structured approach in one particular very large hospital, in this case, Addenbrooke's, to understand where the bottlenecks were, the actual bottlenecks and the potential bottlenecks, such that oxygen supplies would be reliable, would be up to the scale that were needed, and to provide the data in the most useful and accessible way for those who needed it to support decision making. Second project, as an example, was around, in the early days, issues of testing, if you recall, were very much in the news because the testing system hadn't really scaled to anything like the level it is now. But having members of staff in hospitals who might be transmitting COVID unknowingly, we needed to have a process where they could be tested very quickly. So again, coming in to look at the process by which staff were tested. How can we deal with literally the layout of the testing process? How can we speed up the automate? Can we start to automate some of the tasks within the testing process? And can we actually make sure that the assignment of the right test, the people who need the testing get it at the right time? And there's a prioritization system to make sure that the knock-on effect of staff being unavailable is minimized as much as possible. And then the third project was saying, we don't know what's happening next. No one knows what's happening next. So doing some discrete event simulation on a whole series of activities with different scenarios to say, well, what if? What if this happens? What will be the effect on resources for the hospital? And this could be around, as was shown here, around ventilators, around oxygen supply, and even occupancy of the mortuary, just making sure that it was anticipated what might be needed to allow preparation to take place. So giving the decision makers the information they needed in a way that was accessible based on reliable contemporary data was absolutely critical. So those sort of projects were done at great speed in a way that that the local NHS found very helpful and very supportive, and that's led to further collaboration. So it's engineers looking at an urgent and important problem and applying good engineering skills to get the right data to the right people at the right time. Second area was around engineers able to look at the big, messy world of manufacturing and what was happening elsewhere in the world and saying, can we capture useful data for what's happening elsewhere and feed that through to ensure that our policymakers have as much information as possible to help them make better decisions. And so what we saw is colleagues going and looking at the way in which other governments were implementing things very rapidly and looking at, had these things worked? What have these things been trying to achieve? Could we capture the key lessons from that, put it into an accessible format that is appropriate for decision makers operating under extreme conditions of pressure? So there was reviewing what others are doing and presenting it back. And again, the engineering mindset to say, what's good enough? What's necessary for people to know at the moment? Not what's the perfect answer, what's the perfect paper we could write on this, but what do they need to know now? And then providing direct input to our policymakers and our politicians to say, there's all this stuff going on, but this is how it is perceived from an engineering and from a manufacturing perspective. And there's our colleague, Dr. Carlos Lopez Gomez, talking to colleagues in the UK Parliament. But also thinking about, how do we make sure the whole infrastructure of our society continues during all this? Do we understand, if we start locking things down, what does that mean for our food supply? So our colleague Jag Srai, looking at the way in which getting the right information to those who are responsible for ensuring we have the food we need during a pandemic. All of that collecting of data, packaging it, getting it to the right people at the right time was really, really important and well received. There are also lots of engineers charging around with great ideas for solutions to various COVID challenges, but finding that there were blockages. So our colleague Frank Tietzer and his team, looking at the way in which intellectual property could actually be a barrier, because if you can't work out if you're allowed to use a particular piece of technology to solve a COVID problem, it may not get used and you'll cause all sorts of problems. So very rapidly providing those who need to know what the IP issues, the intellectual property issues around COVID, and then working with colleagues around the world to come up with the idea of an engineering-led pledge to say, if you're using this for COVID, you can now use this technology. We've got a way to allow you to use technology that deals with that overcomes all the normal barriers associated with intellectual property usage. So then coming to into the two case studies, but first just a little focus on this idea of the physical products. Actually, stuff was needed, and stuff was needed at scale in the right place at the right time. So we saw a fantastic response from the maker community. And in a Cambridge context, we have the wonderful Makespace, which got together and said, there's stuff we can do, and we can do it well. And a key part here is this issue around, it's no good having enthusiastic engineers making lots of stuff and turning up at the hospital going, here you go. Really understanding what the customer needs and understanding that just making a thing that's useful, if you can't say, how has this been made? Have we got a process here? Have we got process checks? Can we validate everything that's been done? There's a very high chance it won't be used. It can't be used. And so by having engineers working as members of Makespace in Cambridge who had experience of medical device development and the medical world and the engineering world, Makespace could deliver a huge range of basic items very quickly, very effectively. And we saw this also across, with a reach across the world. Again, colleagues such as Lucia Corsini and James Moultrie working to say, there are things that we've got working in our context, and we in the UK context, but we can see from experience of working overseas that there are a very different set of needs elsewhere. But how can we make sure that we deliver the right things that are appropriate? We help local communities develop the right things to allow them to cope with some of the worst effects of COVID. And the project in Malawi is a great example of that. And again, bringing together the maker community from around the world to say there's lots of good things that the maker community can do if it understands the way in which the healthcare systems needs to absorb new products and pieces of kit to be used in a hospital or elsewhere in the healthcare system. A particular one that attracted a lot of attention was this around ventilators. So virus strikes, respiratory problems. As I said earlier, in the UK, they worked out we had about 8,000, needed 30,000. So how do you solve this? Well, you can cut and buy some more. Well, there weren't any. It's a global pandemic. There were no more. You could make more. And we saw the brilliant experience of the UK Ventilator Challenge and a whole load of other activities that rapidly increased the volumes of ventilators that could be made. But also we could see a chance to use fewer ventilators. A good engineering solution, just go through the logical questions and go, but couldn't we do something like sharing a ventilator? Now this can be done, but it needs some quite clever technology to make sure it's actually dealing with two potentially different patients with different breathing needs. So there's a drawing, a sketch, a schematic of what was going on with this ventilator sharing device. And there is what it looked like in its initial form with Duncan McFarlane overseeing it there. But I'll just show you a quick video to see what this thing looked like in practice.
When COVID first bit, many countries, including the UK, were worried they'd run out of hospital ventilators. They're the life-saving machines that breathe for you. The second COVID wave could still leave hospitals short, which is where this new device comes in. It's one ventilator, but for two people. You can see clearly here what makes this device unique. So imagine these bellows are human lungs. Now, the one closest to me isn't going up very much at all. So that represents a smaller person with a smaller lung capacity. The far one is going up far more. That's a bigger person with a bigger lung capacity. So one ventilator able to cope with two very different people with very different needs. It's been designed by doctors from Royal Papworth Hospital and engineers from the University of Cambridge.
This device allows us to instantaneously double the capacity of the ventilators in international humanitarian disaster situation or a mass casualty situation. We are fortunate that we've got enough ventilators, but there are other parts of the world in developing countries where they might struggle with resources as well as infections like COVID at the same time. You could see the potential for a device like this to be used to save lives.
So you see there a nice example of engineers and healthcare professionals coming together to solve a particular problem, which, as it turned out, wasn't needed in the UK, but has potential elsewhere. Similar, this project here, colleagues over at the Whittle Lab and other bits of the university, focusing on the idea that could we design a ventilator that's just much easier to manufacture? And again, really nice to see the way engineers came together with people from chemical engineering and biotechnology and all sorts of other bits of the university. And that open COVID pledge I mentioned earlier allowed them to show how this could be deployed elsewhere around the world, particularly for low and middle income countries. So what we saw is this happening all across, great activities happening in Cambridge, great activities happening across the country. And just to pick up another example here, there was this wonderful example of UCL working with Mercedes F1 to come up with the scalable design for a CPAP machine, a positive pressure face mask you can see in the top left corner there. And what's been brilliant about this is it was made available through to a great collaboration and has now been deployed elsewhere around the world, developing and delivering a solution that's appropriate in different contexts. A great story there. And so what we see is engineers managed to do a whole bunch of stuff very quickly, very effectively. And it was great that the Royal Academy of Engineering acknowledged this and highlighted some of these examples as being outstanding contributions of engineering to helping us cope with COVID. But the issue is that hasn't gone away. COVID is still with us and there'll be other things coming along. What have we really learned from this? Well, really to learn from it, we need to look at some of these things in a bit more detail. So I'm now going to hand over to Rob to talk through one particular example. And I'm going to do he's going to tell me, next slide, please, but he'll take over the conversation from here onwards. Rob, over to you.
Brilliant. Thanks, Tim. And thanks everyone for attending today. I hope that we can be enlightening about some of these more detailed case studies. The one that Tim has asked me to talk about seems like it was only yesterday, to be honest, but we kicked this off back in the middle of March 2020, right at when we were suffering from that initial brunt of the COVID pandemic, and everything was very uncertain. You know, we didn't know, for example, like you were just hearing what the demand for ventilators would be like, but we were also suffering from massive disruptions to the PPE supply chain. As I'll explain in a second, what this project did was establish a temporary warehouse, and in fact, an entire temporary logistics system to support the flow of PPE into Addenbrooke's and the other Cambridge University hospitals. And over its 6 months or so of operation, we handled around 2 million items. And I guess the key thing was that as the IFM, we were engaged in every aspect. Most of the volunteers at the warehouse were IFM staff or students like myself. And we supported in the design of all of the operations and logistics, and an IFM spin-out, Redbyte, was also involved in helping us develop the software systems that ran this temporary warehouse. So Tim, can we go to the next slide, please? So what happened at the very start of the pandemic was that we saw demand for PPE actually increase a little bit, but not as dramatically as the supply that was available at the hospitals decreased. And there were a whole load of reasons for this. There were issues with exports from China, which had closed a lot of its ports. There were issues with manufacturing in Indonesia and Malaysia, where factories had been closed due to local outbreaks. And there were a whole lot of new different demand nodes inside the UK. So places that previously hadn't thought about PPE on a regular basis were now needing to use it all the time, like doctors' surgeries and pharmacies. But Tim, if you click on, you'll see what really happened, at least in the case of Addenbrooke's, in the immediate term after that initial reduction in supply, is that there was a massive surge back again in supply. And this came, Tim, if you click on, in the form of donations. Tim, if you just click through, I think a few examples will appear. There we go. So there were different donations coming in to support the hospital, from everything from members of the public, donating a few masks they had in their shed from their own woodwork project or something, all the way through to the university itself donating thousands of gowns from its laboratories that could be used in the hospital. And all of these things were in demand by Addenbrooke's, but there was not in demand at the rate they were in supply, if you like. We needed a way to buffer this massive surge in supply so that it could be used by the hospital over a longer time frame. And that's where the need for a temporary warehouse came in to provide that buffer. Tim, if you click on. So we needed to establish this temporary warehouse, and we had luckily a few options available to us. At this point, all of the students had been sent home from the university. And so the colleges, sports halls, lecture theatres, all of these rooms were available if we needed them, because there was no physical in-person teaching happening. And with that range available to us, we based the warehouse at Homerton College, who benefit from having a really large sort of sports hall auditorium area right in there, with access directly into their main car park and entrance. But also it's the closest large building that the university has in proximity to Addenbrooke's. It's a 5-minute drive away. And that's straight down one road. It would have been much better than basing it out, say, in some of our buildings in West Cambridge, where the Institute of Manufacturing is. Tim. So initially, the operations of the temporary warehouse were quite simple. The goal was to redirect all of the PPE donations to this new facility, where a team of volunteers would just sort them into broad categories where they could be stored and then collected later by the hospital. And this, we're talking very broad categories here, separate out the face masks from the hazmat suits, from the goggles, from the gloves. And that was initially, for the first few days, how our operation started. But Tim, if you click through, and So if you go again, you can see that what actually in reality happened was that although the hospital had thought at the start they'd be able to collect from the temporary warehouse, this wasn't possible because they were just overwhelmed in other ways. They didn't have the resources to spare to do that. And so within the first week, we found ourselves increasing our operations to have a delivery system as well. And in fact, we brought in a couple of vans that had been used by the chemistry department and some lab technicians who knew how to drive the vans, and they, on a completely voluntary basis, supported us in doing sort of shuttle runs between the warehouse and the hospital on a daily basis. And things also expanded at the front end of the operations too. So Tim, if you click on a couple of times, actually, we added, first of all, the need to inspect items, because, well, some of you might remember there was this big news story back in April or May 2020 with this plane load of gowns being flown in from Turkey that was sort of hailed as a national news story here in the UK. But it turned out to be not great because those gowns weren't up to the standards that the hospitals needed. They were basically fraudulent PPE. And we were seeing a lot of that coming our way too. When there was a massive surge in demand for something, the incentives inside the supply chain and the manufacturing system went a bit out of whack. And so we found ourselves having to sort out and inspect all of the PPE that was coming in to make sure that we separated out things that were useful for the hospital from things that looked like they could be, but were in fact actually not up to standards. And that was a big task because it involved training all of our volunteers who were just students or administrative staff from the university in how to identify a fraudulent FFP2 mask from a non-fraudulent one. We also took on the task of unloading all the deliveries, which seemed trivial at first until we received an entire articulated lorry full of about 600,000 face masks, which took us half the day to unload. I think there were some big tasks in that early stages. Tim, if you click on a couple more times. So we also ended up, once more, we also ended up having to schedule deliveries coming in because a lot of the donors we were having were really generous alumni who were based outside the country. And we were having donations flown in from, say, China, actually flown into the UK to Heathrow and then shipped up to Cambridge. And so managing that inbound logistics also became part of the task, as did providing a whole load of information to the hospital so that they could more actively place orders. What we started to see as the crisis unfolded was that patterns of demand changed. Initially, there was a shortage of respirator masks, but over time, this evolved into a shortage of gowns and goggles, and then into gloves. It really sort of, the exact location of the shortage in the supply chain moved. And so by providing transparent stock and quality information through to the hospital, they were able to every day place an order with us in the morning for what they wanted us to deliver, and we deliver later that day. And we, just due to the sheer generosity of our donors, the alumni, the people of Cambridge, we never actually ran out of anything that the hospital needed. And on the next slide, please, Tim. So one thing on that transparency of information that I would just like to mention in a little bit more detail is how we used Redbyte's technology called Itemit, and they're an IFM spin-out. And the software they normally provide is an asset tracking tool, sort of thing that is used actually around the IFM to keep track of whether toilets are flushing correctly or whether the kettle in the kitchen is working. But here we kind of repurposed it as quickly as we could to make it work for managing stocks in a warehouse. In fact, we ended up adding completely new features working with the development team. And that meant that we were, even though at points we were handling millions of items through this little temporary warehouse, we were able to keep track of everything and do it in a very user-friendly way. So enormous credit to Redbyte and Itemit for their support there. Once more, please, Tim. And in fact, if you just click through a few times just to unfold the whole timeline, and I'll talk through it. So operations started just before the first lockdown, and we really had a couple of days to get things up and running before the first PPE started to come into the warehouse. And so in terms of a temporary task, this was really an urgent situation. And I think we can all remember that. from about the start of April, that's when we started to see our operations expand a lot. The word got out, the university was doing some publicity, some very generous large donations started to come in. And that's also around the time we started seeing this problem with quality in the inbound supply chain and having to run inspections. And we also, in May, we had the British Army come and visit. They were assessing what would be needed if something like this was to be scaled up for the whole country. And we were to have a network of temporary warehouses handling emergency PPE supplies for hospitals. And so they actually took some advice from our model, and they rolled it out onto a Cambridgeshire-wide basis with a hub based in Alconbury that was then supporting the non-acute PPE needs of Cambridgeshire, so everything other than hospitals, basically. By the end of May, we'd handled over 1 million items through, and that was dominated by face masks and gloves, because those were the items that were most in demand and that we kind of requested donors to specifically donate, and that request worked really well. But by the middle of June, things had started to ease off with that first wave of the pandemic. And in fact, that was the 11th of June was the last day we made a regular daily delivery, and we've been delivering 6 days a week until that point. Over time, the pattern became less regular, larger deliveries as Addenbrooke's had more capability themselves to store and manage PPE. And finally, by July, we were kind of in the phase of winding down. We made some large donations of the leftover PPE stocks to local healthcare providers and other local businesses. And finally, before the start of Michaelmas term 2020, we gave the building back to Homerton and closed the warehouse. So it was a really busy and incredible 6 months for everyone involved. But the operational capabilities that we created with that warehouse really helped smooth out the PPE crisis here for Cambridge University hospitals, at least. And actually, we ended up taking a load of the lessons we learned forward when we started to work on the university's COVID testing program, which you'll hear about from Darius now.
Rob, brilliant. Thank you very much for that. So just to remind people where we are in this, we've kind of an overview of the broad things that were happening. We're now digging into 2 specific case studies to see, to share the detail of this, because sometimes the detail gets lost and forgotten. And if we forget the detail of this, there's no chance this can be used elsewhere. While we're doing this, just to remind you, if you've got any questions that you'd like us to come back to at the end, please just type them into the Q&A button on your screens at the moment. But now I'm going to invite Darius to switch his camera and microphone on, and then I'll continue to act as the IT support in the background. Darius, over to you.
So thank you, Tim. So my name is Darius. I graduated from MET in 2020, and I'm currently managing the logistics for the university's COVID-19 testing program, which I'll briefly cover today. So I guess as a bit of background, in August of 2020, COVID cases were of course quite low, with the country opening back up again and restrictions easing. However, it was anticipated that there would be an increase in prevalence after the initial restrictions had lifted, given that students would return and mix, and so we needed a system to ensure the safe return of students. This is also prior to the government-provided lateral flow mass testing program. So next slide, please. So if we just look at a bit of background on how the program got started, the university managed to get an allocation of 2,000 tests per week from the McLaren building, which is located on the Addenbrooke site, and at the time was being set up as a government lighthouse lab. The initial goal of the program was to test all students living in college accommodation, which is a total of over 16,000 people. The program's clinical leads, Dr. Nick Matheson and Dr. Ben Warren, proposed implementing a pool testing program. So here you group 8 to 10 students within a household. They're each given individual swabs, and they're placed into a single test tube. And so only if this pooled result, this one individual test tube, returns positive, do the students then get tested individually, and there you can identify which students are positive, and this greatly reduces the number of tests that you need to do. In late August, once the pool testing approach was deemed feasible, Professor Duncan McFarlane was called in to advise on the program's logistics, and this turned into a team of IFN staff and students and graduates, including Rob and myself, who we were rapidly assembled in order to develop this logistics system for the program, and in order to enable several thousand weekly tests to be delivered, administered, and then delivered ultimately to the lab to be processed. In early September, the program was announced to the press, which placed additional importance on the pilot's rollout and success. Next slide, please. So this is an initial, sorry, next slide, please. Yep. So this is actually a preliminary table, which was created by Professor Duncan McFarlane. And here we realized the importance of separating what's inside the colleges and outside the colleges. So we wanted to try and minimize the number of inside college operations that the colleges have to deal with and students, and try and centralize as much of that as possible. And so colleges were left to handle sample collection, but the rest of it was handled by a single entity, which became the logistics and packing team. Next slide, please. So the initial program faced some initial challenges. Most obviously, there were no specific systems or infrastructure set up in place or personnel in order to handle the program's logistics and packing. We had to interface with 37 different organizations, colleges, including the Theological Federation houses, which, given that many colleges have multiple sites, meant over 50 delivery sites that we had to contend with. We only had a limited number of testing capacity for the program to use, and with only 3 to 5 weeks, well, with only 3 weeks until the pilot and 5 weeks until full testing was launched, we had to obviously find shortcuts in terms of purchasing, recruitment, and delivery. We had to obviously keep things as flexible as possible, given that specifications would change, as this hadn't really been, a mass pooled testing program hadn't really been performed before. And yeah, so if you can, next slide, please. So here we can see the high level logistics plan that we set up, and you can see it's relatively simple and linear. So on the left, it starts with the procurement of parts and manufacturing of test kits. Those test kits are then distributed to colleges. Students then take their subsamples, and this is then used by the students. And then the used test kits are couriered on from the colleges to the testing lab, and then the PCR samples are processed, and then a result is then delivered back to the students. Next slide, please. However, once you include student flows and what the actions that students need to take, we can see how integral that they are to the system's logistics. So colleges up here manage the last mile distribution. So once the test kits are delivered to them, they hand them out to students and then collect back used kits. Students then obviously need to use those kits in order to submit their test results. And this obviously does create some failure modes, which we have less control over. So things like late submission of scans of test kits, and then unforeseen problems with IT. Once they're returned to the lab, if the pool is positive, then the students are individually tested again. And if negative, then the entire pool is deemed to have tested negative. Next slide, please. So here we can see our final product line, which is the 3 products that we currently make and pack within the university. 2 of the kits go out to students. That's the pool test kit and the individual test kit. And 1 is used by the nurses at the engineering pod. So if a student or a member of staff is symptomatic and they go to the engineering pod, they'll be using 1 of the test kits, the symptomatic test kit on the right. Next slide, please. Here we can see the changes, given that the system is constantly adapting and that we're learning all the time, and we improve the system as time progressed. So obviously, as this hadn't really been done before, we had to make multiple changes and kind of feel our way through the system. So initially, students are provided with a bespoke test kit. So the test kit was addressed to a specific student, addressed as the pool lead, and then the rest of the students within the pool were assigned on the label. And so obviously you can imagine the complexity that this required in terms of the logistics system, because we had to deliver specific test kits to specific students and make thousands of them on a weekly basis. And so in order to simplify this process, we then switched to a self-assigned system where students could just take out their phones and then scan the QR code on the front, and then it would assign that test kit to that student. And so then we went through multiple iterations where we reformatted in order to simplify the process and then reduce complexity. And so finally on the right, you can see the final test kit that we're currently on. Next slide, please. So I'll just quickly go over the main systems of the main processes that we have. So warehousing, then packing of test kits, finished goods, the courier, and then obviously the samples then go to the colleges and then to the lab. Next slide, please. So just to quickly go over the warehouse. Yes, just to go over the warehouse quickly. So inbound deliveries to the production facility are tracked using the QR code-based tracking app that Rob mentioned previously, Itemit. We've got QR codes dotted around the production facility and track inventory as it moves between rooms. Data can then be extracted using the Itemit API, and so we use that data to provide real-time monitoring of stock levels, to trigger reorders automatically based on forecasted demand, and to avoid unexpected stockouts that could impact production or impact the number of kits that get sent out to students. Next slide, please. So production itself, or packing, is driven by test kit label printing, which is based on the data, based on forecast data, and based on the number of kits that have been scanned by the students. The envelopes are printed with generic test kit information and then applied, and then all the components are packaged within the tests. The barcode tubes, have a barcode on them. This barcode is then scanned. And then the envelope label is also scanned. And so that then creates a relationship between the barcode on the tube and the barcode on the envelope. That means that the barcode on the tube can be completely wholly random. And if it's, if we lose a sample or if it's intercepted, there's no way to link that single tube back to any specific students. That can only be done after it's safely within the database after results are provided by the lab. Next slide, please. So a critical aspect of the program is ensuring the timely delivery of test kits. And so it's particularly important that the samples that have been taken by students are delivered within 24 hours, because obviously we're trying to minimize the time in order to minimize the time that students spend in quarantine, and also make sure that students know as soon as possible whether or not they're positive. And so we have to have we obviously used, well, we tried to minimize, sorry, just a moment. In order to minimize the number of resources that we use externally, in order to make sure we've got as much control as possible, we ended up using the university messenger service, which is the university's internal courier network, in order to deliver test kits from the lab, in order to deliver test kits from our production facility to the colleges and then to the lab again. We currently have 2 couriers who run on independent schedules and have separate responsibilities. So one courier deals with the pooled test kits, the brown test kits, and it tends to be on a fixed capacity. And then the other courier, who deals with the drop boxes and individual test kits, these follow-on test kits, is able to more flexibly change their demand in case there's an outbreak and we need to collect more individual test kits. Next slide, please. So a critical aspect, another critical aspect of the program is ensuring that we collect and deliver test kits rapidly, and also that we ensure that we're able to track them. And so by using Itemit, we're actually able to track where boxes are, in which locations, whether they're in colleges or at the facility or in transit. And so we actually developed a Python web app to see the last scanned location against where we expect it to be at that given time. Based on the daily courier schedule, and also based on our internal models. And so box locations are then recorded within the Itemit program. And so by accessing their API, we can then cross-check those boxes, and then any boxes identified as being in the wrong place, we can then follow up on rapidly and make sure that samples are delivered back to the lab. And so as a result, we haven't lost any student kits in transit, and they've all successfully reached the lab. Next slide, please. So because the IT system built by the UIS, so the University Information Services, was quite comprehensive and robust, it meant that we're actually able to query it using SQL. And so it's possible to extract useful and accurate operational performance data. And so we're actually able to use this resource to rapidly answer ad hoc questions, as well as build functional dashboards linking directly to the database. And so this here is just a quick image of one of our dashboards, and probably the most useful to look at. you can see that the bars, the blue bars, represent weekly test kit production figures. Light blue here is pooled test kits, and dark blue is individual test kits. And the lines represent weekly test kit usage by students. Orange being pooled test kit usage, and purple being individual test kit usage. And so here you can see at the beginning of the program, when we had the specific pooled test kits, we found that they were produced to a specific order quantity based on the number of pools, as they were all bespoke. And whether or not they were used, we still had to produce more, as it was only valid for a specific testing day. Currently, and also after the start of Lent term of 2021, we switched to generic pool test kits, and so this has caused more variation in our production numbers, and meant that, yeah, I mean, simply yes. Next slide, please. So just to add, so operations are still continuing to this day. So far, we've delivered over 100,000 test kits in over 5,000 individual deliveries. And obviously, we're continually learning and adapting to changes all the time, given changes in government policy, university policy, and as the pandemic unfolds and develops. We actually were lucky enough to be visited by multiple government groups, including from Number 10's health advisor, Will War, who you can see pictured here on the left. Thanks.
Darius, great. Thank you very much. If I could, so I'm just going to make a couple of comments, and then Darius and Rob, if you can switch your cameras back on again. So what I hope you can see from what you've just heard there is we've tried to paint a picture that engineers got involved in a huge range of things to address a multitude of COVID-related challenges at a time of extreme economic and social pressure on all our lives. And what we're a little bit worried about is that a huge amount of those great efforts that were made, all the learnings that took place from them may now just get lost. And that would be a tragedy. It really would be. So what we're trying to do is to say, okay, well, stuff happened during COVID, great responses were put forward. It is great that prizes and awards are given out to recognize those who've done this work. But what we at the IFM and at the whole of university wants to do is to make sure that the things we've learned through this process are used to inform and help those who are going to face the next crisis. So we've talked a little bit about hospital logistics related things, about policy related things, and about the shifting around of physical products. But could I ask, as we head to the Q&A session, for Darius and Rob to switch your cameras back on, please, and your microphones. And I'm going to stop sharing so the three of us now appear here. So I don't want to put you on the spot here, Darius and Rob, but given that this is an alumni event, what is it from when you were studying here at Cambridge, what is it that you took from that learning experience that you've applied in these contexts? What made you able to do this? Because what you've both done as part of teams on these two projects is quite extraordinary, but how much of that is linked back to what you've been learning? Maybe Rob first.
I think so. Darius and I both, as our undergrad courses, did the manufacturing engineering Tripos at the IFM. And in the fourth year of that degree, in the master's part of it, we were on a monthly basis sort of dropped into different industrial settings for 2 to 4 weeks at a time, sort of given a small project to solve. And I think one of the skills that develops in you is sort of the ability to very quickly understand and dissect a problem. So many problems we face are so complicated and so interwoven in many other problems. But as engineers, we're taught to throw out everything and then start to slowly build up the complexity of your model of the problem until it is good enough to understand what's going on, but not so complicated that it's not solvable. And so, for example, with the PPE warehouse, we weren't trying to solve a national PPE crisis. We were very restricted in what we were trying to do. And we kept the scope very clearly defined, even when things started to get challenging and more obstacles were thrown at us. And that's one of the strengths, I think, of the engineering approach to problem solving.
Darius,
I think just to add to that as well, within the manufacturing engineering Tripos, you also are exposed to so many different subjects and so many different areas which you wouldn't normally be exposed to. So even things like organizational behavior and management it is something that we actually found was quite challenging, especially once you factor in things like many of the team that initially helped on the packing side had been furloughed from other departments. And so you have interesting dynamics that show up where you have team members who you have members of staff whose team members in their previous line of work are furloughed, and they've obviously come in to help out for a bit. This is which is stuff which doing manufacturing engineering Tripos gives you this baseline understanding and theoretical knowledge of. So yeah.
Well, it's lovely to hear such positive endorsement for the manufacturing engineering Tripos, and I guess that really key point about we need people who've got interdisciplinary skills, that the things you both did and the projects you were both involved in required a level of technological understanding, but also of everything else. And had you charged in there all guns blazing with a technical solution, I suspect that not much would have really been done. It's the fact you could understand the problem. Is that fair to say, Rob?
Yeah, but I think also it's not a panacea. There were definitely, like, both Darius and I have learned a lot about managing people, especially people who've not got any or not got enormous motivation to be doing what it is they're doing, whether it's coming in every day during a global pandemic to unpack boxes of gloves, or whether it's putting swabs and test tubes in brown envelopes. Like, that's not something either of us was prepared for. And I think certainly Darius is still learning a lot about that now. The people have been the hardest part of the system.
I think also, just to add something that I found super interesting was also scale. So obviously we were exposed in our undergraduate degrees to projects, but nothing really on the scale of millions of items of PPE or hundreds of thousands of test kits, as in on a personal level.
And again, if I can maybe just pick this up, so the stuff you had learned that you were then able to apply, but what have you taken away from this, having gone through this process, this extraordinary, hopefully only once in a lifetime experience? What do you both take away from it that you go, right, from that, I can now see how this needs to happen? Any thoughts on that?
I mean, this is the subject of my PhD, but I think we've learned something about temporary operations during this pandemic, that often we talk a lot, the IFM has a whole research centre devoted to the industrial resilience, and we talk a lot about making industry more robust to change and able to withstand and carry on. But events like COVID, I hate the term, but they're black swans, and they're things that you could not foresee, and when they hit you, you probably aren't robust enough to withstand them. And instead, you've got to be able to respond quickly and do different things and mobilize people and resources in entirely new ways. And I hope that sort of in a larger, beyond just the IFM and Cambridge, we're going to learn a bit about that nationally and internationally. Something the humanitarian sector has been very good at, but we've never really needed to think about in richer countries.
So I think I would completely agree with Rob, and I would also add that COVID has, the pandemic, especially from a general manufacturing perspective, has shown the importance of being able to scale up and scale down your manufacturing capabilities as a company or even as an organization, and being as flexible as possible. And so even though, as Rob mentioned, COVID is a bit of a black swan event, we can already foresee situations that may arise in the future, including the effects of climate change, food scarcity, and even things like the current global chip shortage.
Absolutely. So that's really good to hear, that the stuff going forward from this, and yes, indeed, doing a PhD on this subject is a nice outcome from that. But one of the things we really do want to see is these lessons shared elsewhere. So one of the questions that's come in is around how did this happen? How can, with all due respect to you as students, the fact that a hospital under massive pressure and stress and a university going through extraordinary, almost existential issues during this was saying, yep, we're going to get students involved to help solve this problem. There's something really interesting about that, about how the healthcare system and the university said, yep, there's a resource we can draw upon here. I've got a few comments on this to answer the question that's in there, but Rob, Darius, do you want to comment on that side of it at all?
So I think just to briefly quote Professor Duncan McFarlane, who initially asked Rob and I to join the program, the university was looking for highly flexible people who could be thrown at a problem with very limited scope, very limited historical understanding, and basically work their way through and solve it. And I think that's basically something that that the IFM specializes in. You know, just being able to tackle problems that are multifaceted, not just strict technical problems, despite the fact that there's limited precedent, limited scope, and be able to come up with a solution.
It's also, I think, been about building partnerships with the hospital and with hospital staff. You know, a lot of what we did in the PPE warehouse, you know, they needed a problem, they needed a solution to the problem. We proposed a solution, and there was a lot of initial trust exchange there in both directions. And you know, we worked hard to show that trust wasn't misplaced and provide as much transparency into what we were doing as possible, and really engage Cambridge University hospitals in as broadly as we could around the whole sort of temporary PPE situation. And so I hope that it was a two-way relationship. And if the hospital looks back on it and goes, well, heaven forbid there's another crisis, would we engage in something like this again? Well, yeah, it was mutually beneficial.
So I think there's picking up on a couple of related points that have come up in the Q&A, this issue of how do you do that? How do you get students involved? How do you get a university involved in a healthcare system in the middle of a crisis? And for those who are interested in this, we've actually, we, IFM, have reflected on this a little bit and produced a paper you can download, and maybe Lisa and Ella, our colleagues supporting this event, if they can, I'll send them this paper and it can be forwarded to the audience. But it's making this point that it needed trust. In the middle of a crisis, when lives are at stake, why would you trust people who have no, as Darius said, you know, just smart people who can be thrown at a problem without any prior knowledge? Now, the risk of that is you can just waste a lot of people's time if you don't do it well, or if you just don't listen, you just don't understand what the problem is, or you approach with a preconceived idea of what it really is and then leap to a solution too quickly. So I think that question from Madhyo is really, really a good one. And we did ponder this quite a lot ourselves, going, why are we being given this level of access? So I think that's something we can take away from this, and something that does actually inform how this could be repeated elsewhere. However, I think there's also a specific issue around context and the fact that we're in quite a small town, okay, it's technically a city, you know, that it's small. It's a small scale activity where the movement between different places doesn't take very long. As Rob was saying with the warehouse, it was literally just 5 minutes down the road. Everything was done at a very local scale, albeit with high complexity. So what we're trying to do is to say what is unique about this situation and what is actually generalizable from this. And as I said, we've done a bit of research on this. We're happy to share that paper. But we do need to get some key questions that are being asked of Darius and Rob, which is, did you sleep at all during this period? How flat out was this? Maybe Rob first.
I think it matches that graph I showed, which was, you know, one big bump and then lots of little bumps. I think, you know, there was a week or so where it really was, you know, we had no time to stop really, you know, it was just get the operations running, get all the resources in, recruit the people, work out how we were fitting into the network, you know, it's kind of establish all the boundaries around what we were doing. And yeah, there was a very intense sort of week and a half at the start, and then it just came in spurts. I think, you know, the most fun we had, and we did have fun doing it at times, was when one of these articulated lorries arrived with, like I said, 600,000 face masks on it, which is an entire enormous like extra tool truck full of them. And I ended up, using my street WhatsApp group to drag all the sort of people on my road up here in Cambridge who were just working from home down for an hour to unload this enormous lorry. And it still took us most of the day to unload it. And so there was some great fun and community spirit in there too. It wasn't all hard work.
Darius, did you get to sleep at all?
So I think I would agree in the sense that we had this initial spike, although for the program I think it was closer to a month long. Myself and another student by the name of, well, another graduate by the name of Rory Dyer. It was very intense, but I think as Rob mentioned, the fact that you were all in this together, and the fact that you knew that you were doing something positive for the university and positive for the community in general, kind of drove us in that time, despite having many sleepless nights.
Well, I think this is our time is not with us. We're going to draw things to a close now, but thank you, Darius and Rob, very much for joining this webinar today. And what we'd like to share as a closing comment, perhaps with the audience, is this was a unique situation. Extraordinary things happened here, but what we're really proud of is the way that members of the university responded to this in such an energetic way. But we want to make absolutely certain that the lessons from this are made available for others elsewhere, so that we don't have to relearn this every time. So for those who are doing PhDs on the subject, for those of us who are kind of trying to capture this knowledge, we will make that available and would love to carry on the conversation about how this could be rolled out more widely. So all those who've signed up today will receive a follow-up email with a few links in it, and we'll be very happy to, as I said, to carry on that conversation. Thank you all very much for joining in. Thank you again, Darius and Rob, and to Lisa and Ella for organising this. I wish you an enjoyable rest of your day. Thank you very much. Bye for now.